Hi everyone, I want to share a very important and challenging clinical case with you today. This patient initially went to a medical center with what was thought to be a simple cold, and treatment was started. However, within just 24 hours, her condition rapidly worsened and she unfortunately passed away. She was referred to our hospital during this short but dramatic course. In this session, I want to briefly share the key points and lessons learned from a discussion between myself and 4 other specialists, so that if you ever face a similar case, you won't feel as confused or overwhelmed as we did. My name is Dr. Zeinali, I'm an emergency medicine specialist. And I enjoy sharing medical education with you. If you like this kind of content, please subscribe, leave a comment, and let us know what topics you'd like us to cover in future videos. Now, let's get into the case. Our patient was a 33-year-old woman with a history of multiple sclerosis, who was on rituximab therapy. On the morning of presentation, she developed fever and generalized body pain and visited a general practitioner. She was prescribed dexamethasone and azithromycin, however, her pain rapidly became much worse. By the time she arrived at the emergency department, she was screaming in pain. On examination, her pain was mainly located in the abdomen and was radiating to her left shoulder. She had significant tenderness, and the only visible finding was a mild bruise on her left shoulder. Her vital signs were concerning. She had fever, hypotension, and tachycardia. The abdomen was soft, but there was marked tenderness. At first, we suspected septic shock, possibly triggered by a viral infection. However, the very rapid progression of her symptoms did not fully fit this diagnosis. Also, the left shoulder pain made us wonder, was this just incidental, or was it an important clue? We obtained a venous blood gas. Her pH was 7.03, showing severe acidosis. The bicarbonate was only 5, indicating a severe metabolic acidosis. When we calculated respiratory compensation, it was clear that her lungs were not compensating adequately, meaning she also had a respiratory acidosis on top of the metabolic one. We believe this was likely due to her severe pain, which was limiting her ability to breathe deeply. At this point, we realized that the chest and shoulder pain was actually an important diagnostic clue, not a distraction. Her lactate level was extremely high, confirming severe tissue hypoperfusion, given her abdominal pain, fever, and acidosis. DKA was briefly considered, but her blood glucose was normal, making it unlikely. We then obtained a chest X-ray, which was largely unremarkable. No pneumothorax, no mediastinal widening, and no obvious pathology. However, when we carefully examined the soft tissues, we became concerned about subcutaneous emphysema. Palpation was extremely painful, and although crepitus was difficult to assess, the suspicion was high. This raised several possibilities: pneumothorax, esophageal perforation, or gas-forming infections. A chest CT scan was performed, which clearly showed extensive subcutaneous emphysema, without pneumothorax or pneumomediastinum. This effectively ruled out esophageal perforation and pointed toward a severe gas-producing infection. At this point, our diagnosis became clear: septic shock due to a polymicrobial infection, most consistent with necrotizing fasciitis. Her labs supported this diagnosis, showing leukopenia and acute kidney injury, suggesting multi-organ failure. We immediately started aggressive treatment: IV fluids, strong analgesia including opioids, broad-spectrum antibiotics, meropenem, clindamycin, and vancomycin, and vasopressors. We also urgently consulted surgery, as early surgical intervention is the most important treatment for necrotizing fasciitis. Despite a coordinated, multidisciplinary effort, the patient remained extremely unstable and passed away about 6 hours after arriving at our hospital, less than 24 hours after symptom onset. The case was referred to forensic medicine, and the diagnosis of necrotizing fasciitis was confirmed. I have seen similar cases during my residency. One involved a young soldier with inguinal pain who was initially treated with analgesics and later misdiagnosed as renal colic. He also deteriorated rapidly and died within 24 hours. The key lessons from these cases are very important. Severe, progressive pain out of proportion to physical findings should always raise suspicion for necrotizing fasciitis. Flu-like symptoms do not rule out serious bacterial infections or sepsis. The absence of trauma or an obvious wound does not exclude necrotizing fasciitis. If a patient has unexplained severe pain, even with relatively stable vital signs, they should be closely observed, reassessed, and investigated thoroughly. Have you ever encountered a similar case? If so, please share your experience in the comments.